Então não insistiu na cardio?
Então.
Não me fala que ele tá fazendo cardio, eu vou dar uns tapas nele.
É rolo. É
rolo de veterinário,
foi
né?
o rolo que foi...
a apresentação pra Carol.
É gigantesca, cara. Por isso que eu tô usando o meu computador.
Não. É porque...
É 2 GB. Por isso que eu tô usando o meu computador.
Vai online, fica a palestra e a gente fica no cantinho aqui embaixo. Ela coloca, tipo...
não tem como mandar. É 2 GB. Eu teria que, de repente... A não ser que ela tenha um Dropbox, alguma coisa assim, mas agora, essa hora...
Não vai chegar.
Tinha que ter pedido ontem.
Mas aí ela teve um tumor hepático, aí eu mandei ela lá pra Betcroft pra operar. Isso eu já tava aqui. Isso tudo, tipo, à distância. Aí o motorista foi levar pra São Paulo pra operar. Eu sou do interior do Rio, e aí deu merda na cirurgia dela.
Ai.
E aí foi só... Ela foi tendo queda de hematócrito, de plaqueta, e a gente não descobriu o motivo. E aí a pessoa que operou não deu assistência. Eu aqui, eu não tinha o que fazer.
Puta merda.
E ela fez uma transfusão, aí a Thaís da equipe do Rabelo chegou a atender ela em Juiz de Fora, que é uma cidade do lado da minha. Aí fez a transfusão nela. E assim, investigou 1000 coisas. Até hoje a gente não sabe o que aconteceu.
Caramba.
Aí eu sei que no final das contas eu fui, contratei o Rabelo, ele dava assistência, tipo, remota, né, pra fazer tudo. E aí eu mandei ela pro Verus pra fazer 1 milhão de exames de coisas do que tinha que fazer pra investigar. E não, descoberto.
E tá bem?
Tá.
Study pretty in depth the recommendations that we have for humans, and then extrapolate that to veterinary medicine. So, and then they created the recover guidelines. So the recover guidelines, sorry for giving my back to you guys, I'm just using the computer in there. So the recover guideline is essentially putting together all the information that we have available from the human side of things. Obviously, they have much more research and actually much bigger research going on because they go through, all those associations. In veterinary medicine, we essentially have only one. With very limited people actually working on it. But we analyze all the recommendations from all those councils and groups and all that, and we put it together, and we try to match that with what would be the most common causes of CPR or cardiopulmonary arrest, so CPA, in veterinary medicine. And then we created the recover guidelines. So the recover guidelines, essentially the goal was what I just said, which is go through the human literature, extrapolate that to what we know in the veterinary side of things, and then evaluate how we could apply that. And not only that, how we could teach that and make sure that everybody follow the same guidelines, okay? So the way that we did that, we move that over with class and levels. So for every indication, and this was an extensive study, so for every indication from the human side of things, we would evaluate that and we would come up with a class and a level. The class is essentially evaluating the risk and benefit of doing that for our case population. And the level is what is the strength of support or medical support or literature support to really tell this absolutely needs to be done versus it might be just an opinion of expert, or maybe the case population of a study is very low. So we got a lot of, unfortunately, very low levels. As you could imagine, in veterinary medicine, our studies are actually very underpowered. It's just like you see studies in the CPR in animals with like 6 cats. I mean, it's very difficult for you to really extrapolate that information, like what you're going to do with that very low case population. So you will see that the level then is a little bit low as far as that goes. So essentially, for every indication of every step on the recovery guidelines, you're going to have a class. And the reason I'm showing this, I know this is a little bit academic and didactic, but because on my slides, when you see the recommendations, I put in parentheses the class and the level. So you already know, before I have to really even mention how good or not that recommendation is, you already know if there is like a very high class and a very high level, you know that came from a bunch of very good studies, okay? And if you see that that's like a level C or a class 3, you would see that it's actually very harmful for you to do that, okay? So class, as I said, benefit outweighs the risks, and then it goes down 1, 1A, B, and 3. And then level is essentially how strong, based on literature, that is, okay? So the recovery guidelines is essentially broken down into those 5 main domains, okay? And there's like a 7th part, which is like a summary of everything. Well, we're going to touch base about everything, but I'm going to switch to another presentation when we get to the part of advanced life support, so we have a little bit of interaction with you guys. But it starts with preparedness and prevention. So essentially, we also analyze not only the act of CPR, but also how we prepare for that. Like, for instance, this that we're doing today has a very high level and indication for us to do. As a matter of fact, it's recommended to repeat something like this every 3 to 6 months with your staff, okay? So that's why I know Danielle here did some of that with the staff, and we do that with the doctors as well. And every time we have something new, that's the time that we kind of bring that into discussion. So preparedness and then prevention as well. And then goes into basic life support. As you can see in this diagram here, the basic life support is actually the initial approach to a patient that underwent cardiopulmonary arrest. We call that CPA. So what do we do in the first kind of steps approaching that animal? And then you go into the advanced life support. So several important details about advanced life support. And that's the part that I see the most confusion between. You can clearly see who was recovery training and who wasn't. And the advanced life support is when you see that kind of showing pretty evident, okay? And then you have the monitoring and post-cardiac arrest care. In between, I kind of threw that, how to deal and how to use the defibrillator, because that's becoming more and more frequent. You can see like some veterinary hospitals, they are now purchasing defibrillators and using them. That's because we're doing a pretty good job in training them and showing them how to use, and they're becoming also more affordable. Okay, we have one that is pretty good here. The Philips Heart Start is the name of that machine. That machine is actually incredible. So we will learn how to deal with that and how to use it safely, so you don't have both a dog and a technician down on the floor. All right, so preparedness and prevention is essentially taking care of your environment, taking care of equipment, training, and team dynamics, okay? So normally when I do a CPR training, there's a couple of portions of the training. One is what we're doing here right now, which is just talking and going through, the theory and how it works, where all the information came from, some details. And then the second portion, which is normally like the following day, we go hands-on. I have like a training kit, and I have a training little dog that is connected to actually the defibrillator that gives you feedback and all of that, which hopefully we'll be able to do that another day. But let's knock down at least the knowledge base, and then we can eventually maybe regroup and do the hands-on part as well. So that comes with the CPR training and the team dynamics. The team dynamics essentially, in veterinary medicine, it's pretty easy because obviously it's going to be with the doctor that is running the case. But in humans, normally, if you're out of the hospital, then you have really the first responders and things like that. So it's much more important for them to really recognize who is the strongest person there to be like the team leader for the CPR to unfold. In the hospital setting, this is going to be almost always really the veterinarian, because at the end of the day, the responsibility for everything that happens is going to be under that doctor. So talking about equipment, as you can see here, location, storage, content of the equipment, and availability and clear visibility. You see class 1, level A, class 1, level B, that's pretty high there. And those are things that we don't pay attention, like where is your CPR chart located? Is it like something that if you're doing CPR, if you just raise your head, is right there in front of you? That makes a complete difference if you have to look around. Okay, what dose are going to use? Where's that chart, So that makes a big difference. And also, you want your equipment to work, You don't want to go to the crash cart, oh, we forgot to plug in the defibrillator. Now what we're going to do here? We don't have power for the defibrillator, and this dog has a shockable rhythm. That would be a disaster. Okay, so it starts with that. It starts with having a very good crash cart. It starts with have a very good equipment plugged in, charged. Someone needs to be checking that. Remember, Malik, when we put the tape across there? Malik, actually, I think you did the whole course, didn't you? Malik did the whole course with me, and we put the tape over the crash cart. We break the tape, and then we put it on another one. We check what is in there, and there's all the whole, thing going on, and that is, you have to have someone checking those, rewriting the tape every time the tape is broken for any reason. Even if someone bumping the tape and disconnected from the crash cart, someone needs to service that cart. If you're really serious about CPR and taking care of that in your hospital, you need to be very serious about that. Okay, so as you can see, pretty high level of evidence right there. And then the training, high quality training, and also hands-on training where you're gonna actually do quality feedback. You're gonna train your muscle memories, and not just like watching a lecture or anything like that. Really kind of the hands-on. And as I said, the refresher we're kind of talking about every 3 months nowadays, but at the time of the consensus, at least 6 months is what was agreed on. Team dynamics and how we're communicating. So I remember very well also in Malik's hospital, that was kind of the last ones that I did a full training. I watched one of the, I like to go there and watch one of the CPRs and see how it goes. And it was a madness, There was people yelling. It looked like it was an episode of Grey's Anatomy, Oh my God, you get the tube. Yeah, I got the tube. You do the massage. And you do. I was like, what in the world is going on here? And then we did all the training and everything, and we did the CPR together. It was the quietest CPR ever. No shouting, no going crazy. We just, you ask what you want. You have a person that is a leader that's going to run the code. That's what we say. That person is running the code. That person is essentially standing in there and overseeing everything and looking what's going on. There's one person taking notes. There's a person doing chest compressions that is recommended to change every 2 minutes, regardless if you are like a super physical fit and a marathon runner. We did a study at UF with thermal cameras. It was a friend of mine that was doing her residency in anesthesia. With the thermal cameras, in 2 minutes, regardless, we have very fit people and we have not so fit people like me. And we were doing the CPR and it was burning, regardless how good you are. Arms were like red in the thermal camera, okay? You gotta think that there's a decrease in your ability to continue with a good chest compressions with that burning muscle, okay? So that is what we recommend. So that leader is going to essentially making sure that we are running a code and we are adhering to what has been recommended, because otherwise you just can toss that and throw in the garbage. If you're going to do your way and if doctor is going to be their way, then why bother, right? So that's why you have a leader that is well trained in this and they can do the CPR, okay? So let's start with basic life support. Basic life support starts on recognizing first that this is a case of cardiopulmonary arrest, because a dog or a cat that is sick and present to the hospital is not going to say, oh, chest pain, oh my God, I think it's a heart attack. They're not going to do that. You're going to need to recognize that. I'm bumping the microphone. I think they're exploding their speakers in there. Just did like this. Anyways. So recognize there is cardiopulmonary arrest first, okay? So in veterinary medicine, that's kind of difficult because they can have vasovagal episodes, they can have syncopal episodes. It could be like a post-seizure, like a post-ictus phase that you missed the seizure and now you look at the dog and the dog is kind of all salivated and things. So essentially, in order to mitigate those problems, and since the primary part to really the first steps and the time that it takes for you to recognize CPA and start action is so important. Anything that is really flat lateral should be assumed that is a cardiopulmonary arrest until proven otherwise. Okay. Worst case scenario, you're going to start some chest compression, and the dog's going to, what the hell are you doing? You know. Worst case scenario, that's going to happen. Okay. Best case scenario, you just identify a case of cardiopulmonary arrest very early and you started chest compressions, which is the first step that we're going to see there. Okay, you don't want to miss that window. And we're going to see in some of our slides the consequences are really missing even a minute or two that you could have started a good chest compression. Okay, so and as I said, recognition of CPA, cardiopulmonary arrest, and starting chest compressions. Then comes airway management. It doesn't come IV catheter. It doesn't come giving IV boluses, looking for veins. It comes airway management. That's one thing that I already see also happening pretty frequent. One is start chest compressions, the other one is grabbing catheters and trying to look for a vein. The patient doesn't even have an endotracheal tube. We're not even looking into providing oxygen or anything like that, okay? So airway management and then provision of ventilation. That's the basic life support. You don't need a lot of very expensive equipments or anything like this for you to initiate that. And this is the gold time for you to start it, okay? So I think about CPR like a game, because when you start it, you kind of go into phases. And once you accomplish what is recommended to do, like for instance, once you accomplish this, which is the basic life support, I think like, okay, we just unlocked another phase, which is then the advanced life support, which has its own sequence of events that you should follow for you to maximize your return of spontaneous circulation. That's another word for you guys, ROSC. So with basic life support, what you really want to do, first and foremost, is start chest compressions, okay? If, again, any animal that you suspect that is in cardiopulmonary arrest, you should immediately start chest compression. Start as soon as possible, and then ventilation management. What side should I put a dog? It doesn't really matter. Either left or right lateral position, it didn't really change much, as you can see that. The only difference is that those dogs that are barrel chest, you know, like your bulldog, it's probably more efficient if you do on their back, okay? Any other dog, any other cat, does not really matter if they're left-sided down, right-sided down, but it does matter being in lateral position, that's better, okay? As you can see, the level of evidence is in there. External compressions, you have two main theories behind that. You have the thoracic pump theory. The thoracic pump is reserved for those dogs that are at least medium to large, okay? That they have a nice kind of little waist on their chest, a little kind of concave chest, where you would press on the widest portion of the chest. So you're not pressing right over the heart. That's called the cardiac pump. The thoracic pump takes the advantage of that wide chest, and when you press against the chest, you change all the pressures within the chest, and that changing pressure is going to move blood flow. Okay, it will compress cardiac chambers, it will compress all the arteries, it will collapse the veins, and that's how blood moves when you do a chest compression. And remember, when you're doing chest compression, you're moving blood out. Okay, you're essentially providing perfusion. Okay, now for you to for the blood to move back in, you have to allow it to recoil, and we're going to talk about that. The other theory that we have here is called a cardiac pump. This one here is reserved for animals that are like cats, so small dogs, like cat-sized dogs. Anything that you can kind of wrap your hand around, you probably should use a cardiac pump theory, which is either like this, as you can see in that image, or if you're both hands, you can actually press directly on top of the heart. And then this way, you are physically really compressing the cardiac chambers for the blood to move out. Okay, so remember cardiac pump, remember thoracic pump, and then use your judgment which kind of animal is going to benefit from one or the other. Okay, so cats, small dogs, cardiac pump, and medium-sized to large dogs, you would use the thoracic pump. As important as it is to press the chest, is to let it recoil. This is very important, and again, is one of the things that I see us not doing a good job. This is the phase. So the recoil is essentially letting the chest expand again to its original position. Okay, so this is the phase where you actually sucking blood back into the heart for you to, when you compress, to pump it out. Okay, so you're essentially doing like a suction motion. You are reestablishing the intrathoracic pressure, which is a negative intrathoracic pressure, and by reestablish that, you are favoring what we call venous return to the heart. That's the recoil. Sometimes what I really do, I grab on their skin and I pull them up as I press. So I press down, grabbing their skin, I'm doing chest compressions, I press down, sometimes I grab on the skin, and I even pull it up a little bit, okay? Almost lifting a little bit from the table because I want that chest to expand. Sometimes even lifting them on the table so both sides kind of expand, okay? So you're maximizing as much as you can recoil. One way for you to really mess up with the recoil is to lean on the animal when you're doing chest compressions. And one of the most common causes of really leaning is when you're getting tired. That's why changing every 2 minutes is so important, okay? Because you don't notice, but when we are doing the training and we are analyzing everybody, the first thing that I see is really leaning and you don't notice, okay? So you see that you press and you're not doing really a recoil, you're just kind of hanging a little bit in there. And that's when you're very tired, your arms are very tired, and that's why we like to change, very often. So that's the recoil. So now, as far as chest compressions, how should we do it, okay? So do you recognize that ICU? So, okay, compressions rate of 100 to 120 beats per minute in cats and dogs. That's a class 1 level A, so pretty high level of evidence. That's what we should do. Normally, what I recommend is everybody that work there, everybody, my resident made crazy. So everybody that works in a situation where you're gonna expect to see things like that, I recommend using your iPhones and downloading a CPR tempo, okay? And you can set up prior what rate you want. If you wanna do 120, you put in there. If you want 100, you can put in there, okay? So you can set up that CPR tempo in your phones. Compression, so how deep should we go? We say press hard and press fast, okay? 100 and 110 beats per minute, and you should really squeeze about a third to half of the width of the thorax. So it really goes deep down, okay? It's not just moving a little bit. You really want to squeeze that down, almost reducing by half the width of that chest, okay? So if you do that way, if you do that fast, and if you do with that strength of reducing the width of the chest, you will get tired in 2 minutes. I promise you. Well, no matter how fit you are, okay? Allow full chest recoils, as you can see, class 1 level A, for you to allow things to go back, and uninterrupted cycles of 2 minutes. This uninterrupted cycle is very important. I cannot stress this so much because I see a lot of like, we start, oh, but check the pulses, and then you start, and then you stop, and then you start again. Oh, but let's see the ECG, and then you stop and you start again. You'll see in one of my lectures how bad that is, okay? I'll put like a little graph and you'll see how bad that is for you to keep stopping. So if you start the chest compressions, no matter what, the leader, but you should also know that, should never interrupt that if it hasn't been like about 2 minutes, because you're gonna waste 1 minute only to bring kind of circulation a little bit back to normal, or back to the best that you can do. Interposed abdominal compression. I don't normally do this, and I don't normally, there's not really anything disfavoring it very strongly. Luis. So with interposed abdominal compression, my concern is that if it's an animal that just had an abdominal surgery, I would absolutely not do it. If it's an animal that is an abdominal disease, I would absolutely not do it. And the rationale is that you are trying to favor some backflow, some venous return if you interpolate with chest compressions. Otherwise, you're not really doing anything. But for instance, you can see these images here. This was a puppy that underwent CPA because of a heart disease, and we did, CPR. We did actually a pretty good job. There was some interpose and abdominal compression. This is what came back from necropsy. Look at that liver. That liver is mangled, okay, because of the abdominal compression, because this dog had no liver disease, okay? And you can see all this trauma caused, all the bleed and all the trauma caused to the liver because of abdominal compressions, okay? And you would say, how can you even press that hard or do that much damage with abdominal compression? Because you don't know. You are like loaded in epinephrine in running in your body on a cold. You have no idea how strong you actually become when you're super, in the motivation of getting that animal back. Okay. Okay, so that's it for chest compression. So remember, press deep, press hard, and 1/3 to half of the width of the chest, 100 to 120 beats per minute, 2 uninterrupted cycles of 2 minutes, or uninterrupted cycles of 2 minutes. Then you go to the ventilation part. Obviously, if you have more than one person working on it, which is most of the cases here, we have 2 or 3 people that can help in a CPA case. One is going to be then working on the ventilation at the same time. So one is to start chest compressions, and then the other person is going to come in and start working on securing an airway. Okay, so we're going to place an endotracheal tube the best way that you can. It's very important and to start trying to practice intubating animals in lateral recumbency. So if you have the chance, an animal that just passed away or something, you have a tube laying in there, practice. You want to get good at this. You want to be the person that everybody asks, hey, can you get this airway, okay? And that comes with training. Every time you see an animal that maybe unfortunately passed or something like that, or you have the opportunity to intubate an animal in lateral recumbency, you should do it as much as you can, because it will, and moving, because it will come handy one day, okay? Because sometimes it's pretty difficult to pass a tube. With all the movement, with all the chaos going on, it's difficult to pass a tube. You don't know exactly the size you're going to use. You kind of eyeball the size. But that's very, very important. One thing that I normally do is if I'm having really a very difficult airway, you can try to actually guide your tube with your hand, so you can actually, with the dog moving and everything, you can kind of feel where the arytenoids are. You can kind of feel where the trachea are, and you can kind of block on top of it, and then you pass your tube kind of guided with your hand. That works a lot. Obviously, with the small animals, you don't have much of a space there for you to do in your entire hand, but even your finger or something, you can kind of guide a little bit your tube. Okay. Once you have the tube in place, the ventilation, the recommendation is 10 breaths per minute. Okay. So no faster than that. The main reason is that, so you might say, okay, but why can't you just breathe whatever I want? Because I want to give them oxygen, Because remember, you're doing positive ventilation. It's not negative ventilation, okay? So you're positive ventilation. So every time you have a tube in and you're breathing for them, you are introducing positive pressure inside the chest, and the chest is mostly under negative pressure for you to really breathe well. So if you introduce positive pressure, you're going to reduce the venous return, because it's more difficult for blood to come into the chest if the pressures inside the chest are higher, okay? So breathing is really an unnatural way of delivering oxygen, and that's the problem. The problem is that you're introducing a lot of positive pressure into the chest, and that reduces venous return. That's one problem with mechanical ventilation. It's the same thing, okay? So, and then short inspiratory times of 1 second. You don't want to be there in the ambu bag and taking your time and squeezing. Okay, and then let it go. And then again, you squeeze. No, you're going to do 1 second. It's 1 second, fast, 10 breaths per minute with a tidal volume of about 10 ml per kilogram. So obviously you're not going to be calculating tidal volumes during CPR, but you can look at the kind of the pressure gauge and stay kind of between around 20 centimeters of water, okay? So that's the ventilation part. For basic life support, the whole thing about mouth to snout, forget about it. Okay, so for the advanced life support, I actually going to switch to another lecture that I have here, which has a little bit more better graphics than this one that I have. but we're going to talk about you started off with the basic life support, and then we're going to unlock, as I was saying about phases, we're going to unlock the advanced life support portion of it. Okay, so let me just make the switch here. And if you guys have any questions, let me know. Just take this off. There you are. Okay, let's see. Is it playing? Yeah, okay. So advanced life support. So I'm just gonna go quickly here to a little case scenario here, okay? So this is Coco, 4-year-old female spayed mixed breed dog, and she presented in emergency care here with some vomiting, being very depressed, hypovolemic, and essentially, if I skip through here, she was just diagnosed with an intestinal foreign body, and not really that complicated. Went into surgery, had the surgery done. Immediately post-op, she received a hydromorphine for analgesia, and then shortly after extubation, Ethan, which is one of the techs, noted that Coco vomited, took an agonal gasp, and then collapsed. Okay, so here's the thing that if you have a person that has been really trained with the recover guidelines, that person would remember that any sort of collapse animal that is lateral recumbent, what should we do? You should potentially assume that this is a case of cardiopulmonary arrest. And there's a lot of things in there, like for instance, the vomiting and diagonal kind of, or the gasp for air. You're thinking about, okay, maybe like a vasovagal event that led into cardiopulmonary arrest. Okay, so you should essentially initiate chest compression. Okay, it's an animal that is lateral recumbent, unresponsive, just had surgery, just had an opioid injection, which opioid can also cause a vasovagal event. The vomit could have caused a vasovagal event. So there's a lot of items here that could have contributed for this dog to completely arrest. Okay, so as you can see, the group is very well prepared here. You have a doctor, you have 2 nurses. One initiated the chest compressions. The other one is working on getting the tubing. You see the position, she came down on the level of the dog. She's trying to intubate on a lateral position, which sometimes can be challenging. You can use tools to help you. You can use a laryngoscope. You can use your hand, as I was talking about, whichever way you're more comfortable with. So that's the basic life support. So initiation of chest compressions and then ventilation with the specifics that we talked about, okay? And then once that is done, that's when you have that achieved. You have a group that is working on chest compressions, and you have the animal ventilated with an endotracheal tube. That's when you really unlock this phase here, okay, which is the advanced life support, which most people would think that, okay, the next phase, and especially if you're short-staffed or like you have just a few nurses working and not a multitude of people, like it happens at UF. Every time we have a CPR, there's people that come from the streets, because I never seen filling up the room so much. So the next step is not really placing an IV catheter or anything like that. It's really initiating monitoring, okay? You want to connect the electrocardiogram. You want to connect the end-tidal CO2, because those would be very valuable for the next step. Step number 1 is that end-tidal CO2 is checking on how well the person that is doing chest compression is really doing a good chest compression, because you're going to get some number as your feedback. If you can maintain like a number between like 12 or 15, you're doing a pretty good job. If you can bring it to the 20s, you're doing a pretty good job with your chest compressions. But if it's 0, your compression sucks. You better just adjust your technique. maybe you're leaning, maybe you're not recoiling, maybe you're not going deep enough, maybe you're not going fast enough. So just by connecting the end-tidal CO2 to that tube that is already there, already gives you a lot of feedback about how you're doing with your chest compressions. So if you are the person doing chest compressions, you absolutely want that end-tidal CO2 connected. Otherwise, you're just playing with the dog. Okay? So, and then the electrocardiogram, you're connecting the electrocardiogram because before you do all the craziness of giving epinephrine, giving atropine, give whatever you have in there, you can actually have or identify a shockable rhythm, which is much easier for you to convert back to a perfusion rhythm than with giving all the medications. Okay, the medications is really like a last attempt for you to really do something and bring them back. If you have a shockable rhythm, your chances of bringing them back is much higher with the defibrillator. Okay. And another thing is that then obviously you have this monitoring in place, you obtain vascular access, then you're going to work on obtaining vascular access. There are several ways of doing that. I have some videos in there, but for the sake of time, we're just going to go through it. But you can do cut downs, you can do catheter placements, you can use front, back legs, etc. I try as best as I can to use front legs because they're closer to the central circulation, okay? Versus having to use back legs and have to give very big boluses of flushes and things like that for you to bring it up to the central circulation, okay? And then once you have the vascular access in place, really the first thing that you should be thinking about is not really, okay, give me that epinephrine, give me that atropine. Can I reverse anything? Okay, because that's huge, especially a dog that just came out of anesthesia, that just received an opioid, that you can totally reverse that, okay? But it goes completely like, woof, we're thinking about epinephrine, we're thinking about atropine, and we forget that there are medications that could be on board that you can totally reverse, okay? Even if it's been done like several hours ago, this animal was probably sick, circulation was probably horrible. Chances are that you can still reverse a drug that has been hours that you've given is pretty high, and I would recommend them giving it, okay? So essentially you obtain, you put your equipment, you connect the ECG, you connect the end-tidal CO2. Also, obviously, very important to keep your ECG equipment ready to use. Make sure you have the clips, making sure you have the gel. Remember about the gel, don't use alcohol, especially if you're gonna defibrillate the dog, because you can certainly put this dog on fire if you do so. So it's better to use electrolyte gels instead of alcohol. If you're considering using the defibrillator. Also, it's important for you to know, and maybe this is something that we need to check as well, since the equipments that we have here, I'm not completely familiar with them, but they could potentially just break if you're defibrillating an animal and the equipment is connected to the animal, okay? Just because of the electricals and all that. So make sure that our monitors are defibrillator ready, otherwise you're just gonna burn them as well, okay? So that's also important to take a look. Once you have these, so remember, we're doing chest compressions. Let's go to the case. We're doing the chest compression, we're doing the ventilation, we connect the end-tidal CO2, so that's giving already some feedback for the person doing the chest compressions, and you connect the ECG. Whatever the time that has a span, if it is in the middle of the 2-minute cycles, you wait to the 2-minute cycle, but now that you have the advanced life support kind of set, which is the vascular access, you gave the reversals, you have the monitoring connected, that's the time that you can do the first stop. So see that from the time that we started until now, we haven't stopped. We've just been changing people every 2 minutes, but we haven't stopped it yet. Now is the time that you can take a little break, 10, 15 seconds, for you to look at the ECG that you just connected. Because as I said in the beginning, this is the best scenario for you to really bring this animal back is if we see that there is a shockable rhythm. Now we need to know about the shockable rhythms, because otherwise, you're just going to look at the ECG and not know exactly what's going on. So this graph here is just showing what happens when you stop chest compression. So you started at 2 minutes, that's entire like 1 minute in their chest compressions. You got a little bit of perfusion. You stop a little bit just to see things like 10, 15 seconds, and then you do another 2 minutes. So you see, it takes about like a minute for you to even go and achieve some perfusion. If you stop all the time, you're never going to get there. Okay, you're always going to be on the underline here where you could maximize perfusion. So that's one of the reasons why we don't keep stopping if you start your 2 minutes, because you're going to waste 1 minute just to bring it back to perfusion or some level of perfusion. Okay, 1 minute of your chest compression is already gone just to bring it back while you left or while you missed by stopping by 10-15 seconds. Okay, so what you want to achieve is really what we call a perfusion rhythm. A perfusion rhythm on the ECG is going to look like something that is very repeatable. So you have repeatable tau waves. Forget about P waves, QRS complexes, T waves. This is not a cardiology interpreting an ECG. That's not what it's about. What the ECG is about for CPR is to identify if you have a repeatable rhythm and then pulses and things like that, okay? So with a decent kind of, heart rate. That's called the perfusion rhythm. As the examples of non-shockable rhythm would be what we call pulseless electric activity. As you can see, it looks like a completely normal beat, but there's no pulses associated with that, okay? There's not really a repeatable, it's very slow. It's just a random kind of depolarization in there that has no contractility. Okay, this is called pulseless electric activity. It's important for you to understand and know this because this is a non-shockable rhythm. This is not going to respond to shock. So if you see something like this, you should just continue with your chest compressions and then go ahead with all the medications, epinephrine and things like that. Do another 2 minutes and then kind of look at it again until you can maybe find a shockable rhythm. This one here is called, asystole. Everybody, I hope, is very familiar with that. Essentially, there's no electrical activity. There's no mechanical activity. It's just really a flat line. This is a non-shockable rhythm as well. You can shock as much as you can. There's not really any energy for you to use at your advantage by shocking the heart in this phase. Then you have the two shockable rhythms. You have the pulseless ventricular tachycardia, where now there's a lot of electrical activity. There's some mechanical activity, but it's too fast, okay? It's like above 200 beats per minute or so. It's really too fast for a organized movement for flow, okay? There's not really a lot of forward flow. It's very deorganized, it's very fast. So this is also another example of a shockable rhythm. This is now shockable rhythm. And the other shockable rhythm would be your ventricular fibrillation, where you have a lot of energy here for you to convert into good energy, okay? Again, this energy is just going from everywhere. It's not really organized, but there's a lot of energy available for you to really shock it, okay? And convert that to a perfusion rhythm. We talked a little bit about the end-tidal CO2, how important it is. It gives you some information about how well you're doing chest compressions, and also is the earliest marker of return of spontaneous circulation. So I cannot stress how important that is, because if everything that you're doing, all the chest compressions, the ECG, the tube, the ventilation, nothing is really telling you if this animal is back. Nothing. You can check for pulses if you want, but sometimes you can even feel your own pulses and think that the animal has a pulse. That's actually very common to happen, okay? You can see some breathing when you're not giving breaths, but those could be just completely agonal breath, okay? So there's not really anything other than the dog just kind of, waking up completely, which is normally doesn't happen that way. There's not really anything that is telling you if this animal returned before anything else other than the end-tidal CO2. If you look at the end-tidal CO2 and you see that end-tidal CO2 shoot very high up, much more than you could ever achieve, even if you're the best chest compression person in the world, you're not going to get an end-tidal CO2 back to the levels where when you're breathing normally. Okay, so if you're doing chest compressions in here, you're actually getting a pretty good end-tidal CO2. I would say probably around 22 or so, 22. And then you look at your end-tidal CO2 and now it's all the way up there. This dog is back, okay? But you should not just stop everything. You just got an early indication that this animal is back. Now you have to switch gears to how to deal with the post-arrest care, which is another 1 or 2 hours talk about it. Okay, but then you switch gears to post-arrest care, and then unlock another set of algorithm that you can follow for the post-arrest care, okay? But as far as the CPR goes, this is the earliest evidence or the earliest indication that the animal is back. As far as blood pressure and things like that, there's not really, blood pressure, there's not really place during CPR. It's not going to be helpful. Maybe on the post-arrest care. This is what I was talking about as far as venous access, like what is the best place and things like that. I would say, you know, first, front legs are the best. Obviously, it would be much better if you put like a jugular catheter, but go and try to do that with a CPR. That's even worse, you know, with all the movements and everything. Forget about it. So I have some videos of, I can share this with you guys if you want to see how to do cut downs, and also how to secure them, how to do the easy IO, which I think we have this in our crash cart. At least I asked for one. I'm not sure it's in there or not. But the easy IO is this one here. So it's essentially a gun, and it's a gun that comes with its own catheter. You screw that in there, and you just go in the lateral tibia or in the femur and just drill in there. Okay? It's very easy. You can place this in like a few seconds. So that's pretty good. Intratracheal administration, I mean, it's okay, but just know how to do it. Number one, you have to increase the dose of the medication that you're using. Number two, use a red rubber to deliver all the way into the lungs. And number three, what I normally do is that once it's administered, I connect the ambu bag and I give a very strong flush in there with air, okay? So you can do it. It's not done that often, but you can certainly do it. Okay, so I just want to do, what time is it? 8:11?
8:11.
Okay, so let me just do a couple of just interaction with you guys, and then we call it a day. Okay, so I just want to go through this because I feel like that this is important information for you guys to have if you will really start connecting the ECG and evaluating the ECG for the next steps, okay? So when you see an ECG, when you connect the ECG and you are stopping in order to evaluate if it's a shockable rhythm or not, the very first question that you want to ask yourself is that, are there constant repeating complexes? That's what I was talking about in the beginning. Are they really constant and repeated and they look like similar one to another? Depending on your first question of that, you're already going to completely dismiss pretty much, you know, all the defibrillation and things like that, and you start with medications. So if there are no repeatable complexes, does it look like a flat line? If it looks like a flat line, that's the easiest non-shockable rhythm to diagnose, which is asystole. So you're not going to lose your time with the fibrillation and things like that. You're just going to assume that that's asystole. You're going to go through the next phase, which is giving all the medications and then reassess in a couple of minutes. Okay. Now, if there is no flat line, and the line is actually kind of moving up and down in a kind of deorganized way, very likely you have a ventricular fibrillation episode here, which is completely shockable. And then you would need to set up your defibrillator. So normally when you see a defibrillating, a shockable rhythm, you don't say, okay, stop everything, here's the defibrillator, let's do it. You continue with your chest compressions because you want to bring a lot of nutrients, you want to bring a lot of substrate for the heart to respond to the shock, okay? So you continue with that, you set up your electricity in the defibrillator, you put the gel. When you're really, really ready, then that person stops, you put the dog on its back, you hold the dog into position, we're gonna see that with the pads, and then you shock. Once you shock it, you don't look at ECG, you don't look what happened, you go immediately into chest compressions again. Because now that you shocked, and you gave the heart a possibility of converting, you want to again bring nutrients, bring substrate for it to respond, okay? Otherwise, it might not respond just because it's depleted of calcium, it's depleted of potassium because it didn't have all that circulation. So you don't want to shock and see. That's not how it works. You shock and compression, and you compression and then shock as well, okay? So that's for ventricular fibrillation and asystole. Now, if you do see that there are repeated complexes, you check for pulses, because if there are pulses, you have a return of spontaneous circulation, you have a perfusion rhythm. And then again, from here, you would go into the post-arrest care But if there's not really a pulse associated with that, then you look at your heart rate. Okay, so if those repeatable rhythms, if they are with a heart rate above 200 per minute, very likely this is a pulseless ventricular tachycardia, which is a shockable rhythm. Don't wait and see, because that rhythm is just gonna burn everything that you compressed back into the heart. Okay, so you don't wait and see that, because you're just burning substrate. It's going to be very important for the heart to respond to the defibrillation. Okay, now if the rhythm is below 200, very likely you have what we call pulseless electric activity, which is non-shockable, because there's not really a lot of energy for you to use. There's not really any mechanical activity after that. Okay, so we're going to see some examples here. So what you're going to see, so this is just examples. So here you have examples of repeatable. Do you see my mouse in there? Yeah. So here you have examples of repeatable rhythms. And I put this here just for you to see that I don't care if it's deeper. I don't care if it looks like this. As long as they are repeatable in a sequencing here, where the next step is to look what this part here is doing. Okay, so this is not for you to diagnose ventricular premature complexes or weird arrhythmias and things like that. This is really for you just to see if what you're looking in there is repeatable, and if it's shockable or not, which is going to be based on your heart rate. Okay, so let me see if I have the examples here. Okay, so for instance here, and I'll ask you guys this. So question number one, looking at this scenario here. So by the way, this here is an arterial blood line, but this is doing the job of the end-tidal CO2. Okay, which is your earliest indication of perfusion. So if you look at this here, let's say that we stop for that brief 15 seconds to look at the ECG after a couple of rounds of CPR or chest compressions. Are they consistent and repeatable? Yes, right? I don't care if they're negative. They're persistent and they're repeatable, okay? Are there pulses associated with them? No, right? Because there's no pulses. There's nothing going on here. Remember, this is your end-tidal CO2. If there were pulses, your arterial line would be showing waves here, right? Your end-tidal CO2 would be still very low. 8, 10, maybe 12, 15. That's not perfusion. Perfusion would be your 40s, your 45s, your 50s, okay? So there's no pulses associated with that, okay? Is the rate above 200 per minute? No, right? So which kind of rhythm is this? Yeah, okay. So no, PEA, pulses electric activity. Okay, so here, yeah, okay, because you have no pulses, okay? You have no pulses and your heart rate is below 200. Okay, pulseless ventricular tachycardia, heart rate is above 200. Okay, so this is pulseless electric activity. Okay, PEA. What about this one? Are there consistent repeating complexes? Yes, right? One here, and go up and go up and go up, and they are happening here around. Are there pulses associated with that? No, right? There's no flow here. If it was end-tidal CO2, your number would be low. Is the heart rate above 200? Yes, right? So which rhythm is this? Pulseless ventricular tachycardia. Is it shockable or non-shockable? Shockable. So what would you do if you see this? Before shock. You continue your chest compressions, maybe give another 2 minutes while you have time to set up your defibrillator, put the gel, put the jaw that you want and all of that, organize with the people because there's safety involved, right? So you want to set up everything so you take advantage that you still need a little bit of a chest compression before you do it and set up your machine, okay? All right, are there consistent complexes in here and repeatable? Is there perfusion in there? Yes, right? So your arterial line is showing perfusion here. So you're good, you're game. This is a perfusion written. This is where you would unlock the phase of post-arrest care. This is an example of return of spontaneous circulation. Are there repeatable complexes? Any perfusion? So what rhythm is this? A systole. Is it shockable or non-shockable? non-shockable. So the next step is just keep your compressions. Maybe start your medications if you haven't already, like your epinephrine, your atropine, and things like that. Okay. What about this one? Is it consistent? It's kind of difficult for you to say consistent with a ventricular fibrillation, but if you're concerned if it is not consistent, it is a flat line. It's not either, right? So that's when you kind of come to the conclusion of ventricular fibrillation. So it's not really consistent. Sometimes you might say, yeah, but I have one here and one here, but it's not really consistent. You're not chasing waves, okay? We're not interpreting this ECG, okay? So you're not chasing waves. It's not really consistent. You go up and down, very deorganized, but it's not flat, okay? So what rhythm is this? Ventricular fibrillation, yes, and there's no perfusion, right? Ventricular fibrillation, you have no perfusion. Is this shockable or non-shockable? It is shockable, yes, because you have a lot of energy in there for you to use to convert this to a rhythm, okay? So a few more in here. So what do you think about this? Let's do this. Just give me the diagnosis of the rhythm and if you would shock it or not. Yep. Shockable or non-shockable? Non-shockable, right? Everybody with me on this one? Okay. Repeatable, slow heart rate, below 200, no pulses. So pulseless electric activity, which is non-shockable. What do you think? Yeah, ventricular fibrillation. Yes, so it's not consistent, but it's not a flat line. So there's a lot of energy that you can use here. It's pulseless, obviously, because it's ventricular fibrillation. So it's shockable or non-shockable? Shockable, right? What about this? Is it really pulseless?
Oh, there is
Look at that arterial line, okay, which is your end-tidal CO2. So think about your end-tidal CO2 would be like around 59, 50s or so, and then you have a heart rate of 116 with repeatable rate. So this is just perfusion rhythm, right? It's just return of spontaneous circulation, okay? What about here? Yeah, I heard that, asystole. No pulses, nothing going on, flat line, continue with medications, massage, and chest compressions and all that, okay? What about this one? Yeah, look at that. It's consistent, up and down, up and down, up and down, up and down. No pulses, so it's pulseless. And look at the heart rate is above 200, all right? So this is pulseless ventricular tachycardia. You don't wait and see on this one because you're just burning all the energy that you put a lot of hard work to put on to bring it back to the heart, okay? You shock this one, okay? You say, oh, it's just tachycardia. 232 with no pulses is not just tachycardia. All right, this one here. I think you guys already saw one of these, ventricular fibrillation, another perfusion rhythm, okay? So I think for the sake of time, I think that's it. I hope you guys are taking home anything new here. There's much more to the CPR. Maybe we can arrange something, Mateus, that we can actually finish this set of courses. Malik actually participated on that, so he can vouch or not that if it was good or not. But I do have like my mannequins and all of that. I have monitors. I have all those arrhythmias in a arrhythmia monitor or a arrhythmia simulator that I just press some buttons and changes completely all the arrhythmias. So maybe we can put together something like that and do it. Okay. All right. Okay. Thank you guys. Thank you.